Thank you for tuning in to another episode of Help Nobody Told Me. I'm Jasmine Shapiro. I'm with Berkshire Hathaway Home Services here in Chicago. I'm with my co-host, Mindy Leonard, with SOS, Super Organized Spaces.
Yes, that's me.
Yeah.
We're so excited today. We have a fabulous guest, Dr. Suzi Siegel. You were a ER doctor for dozens of years, and now reinventing yourself and becoming a menopause specialist.
Yes.
We are so excited to have you here today. I think the information that you are going to share is just going to be so relevant to our watchers, our viewers, our listeners, everybody, and us.
And
the host, too, right?
And I was lucky enough to hear you talk once, and I was like, we have to get you on our
Aw,
podcast.
thank
And I didn't know you were already scheduled.
Yes,
Remember I went up to
yes,
you, and I'm
was-
like, I have a podcast I want you on.
Yeah.
So, yeah.
Well, thanks for inviting me. I'm really
Yeah.
excited to be here.
So tell us a little bit, like, you were an ER doctor. How
I
did
still
you
am.
You
I still am.
are.
It's you know, I'm an ER doc by heart, so
Yes.
it's hard to get it totally out of my system. But when I started going through changes myself and did a deep dive to help myself, I realized, oh my gosh, this is insane. You know, I've got to help other people. So I did a ton of training, and now eventually I morphed into this, and I started my own practice, which we'll get into.
Right.
Yeah.
So, but are you still in the
So
ER?
I'm still part-time. I still work a few shifts a month. I'm out of a local ER, and I decided, you know, the controlled chaos of a busy ER shift and changing from that to sitting one-on-one with one woman for 90 minutes. I get so pumped up after doing that and getting the wins in that, just as I do seeing all the crises that happen in the ER. So it's the same thrill I get.
Not everybody can say that in what
No.
they do, right? That they get a thrill from that. And how amazing that you're able to do it and get it both ways.
Both ways.
Both ways.
Different energies.
What? So it was because you started experiencing the changes yourself. Did you also experience people who are going through menopause and those kind of things coming into the ER, and you're treating them in the ER? Did that happen?
100%. So we weren't you know, I if you do any menopause research, you know, we were not trained. We are not trained in this in medical school. We're not really trained in this in our residency trainings. And now current day menopause management, you have to seek the training yourself. Hopefully, in the next generation, we'll get back to teaching this properly. But people think menopause care is just kind of the bikini area, you know, boobs and lower down, and it's not. It's a whole body experience. And I see this in the ER all the time. I see the emergencies that come from lack of hormones. So when women are coming in with heart attacks and strokes, but some of it is lifestyle and genetics, but some of it is hormone related, from the osteoporotic hip fractures, recurrent urinary tract infections, frozen shoulders. We put all this together and take a step back and look what else could be causing this. You know, why all of a sudden are all these women between 40 and 60 suddenly having all these issues? And we don't put it together.
Why is it such a big thing today? Like, you're hearing a lot about it today. And I'm so grateful that you trained yourself, right? I mean, you had to, like, you know, either step away or while you were in
Yes.
the ER, start studying and learning, which is not an easy thing to do. And thank you for doing that. But why is it such a buzz now all of a sudden? Like, Oprah had a special about it, and, you know.
I think as all these badass women are starting to experience it for themselves, and we're saying, hell no, I'm not suffering through this. But going from not suffering now to prevention for the decades to come, and that's the key. I think one misunderstood point is people associate menopause with the classic hot flashes and night sweats. But a lot of people don't realize what's happening, all the changes that are occurring, and the dangers of not putting the hormones back into your body, because you're setting yourself for osteoporosis, low bone mass. Women don't realize your cholesterol goes up. People don't realize your risk for heart disease goes up. Recurrent urine infections. Like, people don't realize it's preventative medicine. And as far as having its moment, I think it's just educated women saying, I want to do everything I can to improve my health span, to live as well as I can for as long as I can. And the information is starting to get more out there. We're starting to see a lot of more research happening. and the information is coming fast and furious.
So you mentioned hot flashes and some of the other things, but can you talk about what are like the most common symptoms that women experience during menopause?
So most common symptoms people know about that associate with are hot flashes and night sweats.
Right.
But actually the most common symptoms happen before all that. It's, estrogen is a full body hormone, head to toe. So some of the early symptoms people have, and they don't necessarily associate it with perimenopause or menopause, is what's happening in the brain. Brain fog, trouble sleeping, trouble concentrating, word finding problems, mood, irritability, new onset depression, new onset anxiety, or if someone's had anxiety and depression, like all of a sudden I'm doing all the same things, why is it worse?
Yeah.
Palpitations. People don't realize this can all be related. And those are some of the more common earlier symptoms.
Okay, so you mentioned perimenopause and menopause. What is the difference?
So menopause, the average age of menopause in the United States is about 51 and a half to be exact. So that's when the ovarian function just stops. Your ovaries are said, we're done, we're retired, you can no longer have a kid no matter what you try to do. And the definition really is 1 year without a period, but that's a really sucky definition because a third of women don't get periods. Either they've had a hysterectomy for various reasons, they have an IUD, they've been on hormone contraception the whole time. So the lack of period's not the best definition, but it truly means you've outlived your ovarian function. Perimenopause is the time leading up to that, when you're thinking about retiring, but you're not really quite there yet. So that can last 4 to 10 years. So women in their 30s and early 40s can start having some of these mood changes and sleep changes and body composition changes, and they're not realizing, oh, this could be hormonal.
Right.
So it can start much earlier.
Yeah, and you blame yourself. You don't realize, no, this is actually
and it's not anything you did. A lot of people say, I'm doing everything the same. I'm eating the same. I'm exercising the same. And I look in the mirror and I don't recognize myself. I don't feel like myself anymore.
How does somebody determine if they're in perimenopause?
There's no test to see if you're in perimenopause. It's really symptom guided. So I would warn people, with all these testing, hormonal testing in perimenopause, it's just wackadoodle. On Tuesday at 2, it could be here. On Thursday at 4, it could be here. Because what happens is, in the normal menstrual cycle, it's like an orchestra. You've got your symphony of up and down, where your hormones are going up and down. The whole goal is to try to, conceive.
Let's have a baby.
And then during perimenopause, when you're trying to retire, and you don't have enough eggs left, and things are screaming, your brain's screaming, and your ovaries, come on. So things are just going up and down and up and down and up and down like a roller coaster. So sometimes your levels can be super high, sometimes they can be super low. And you'll experience different symptoms at either end.
And when you talk about levels, you're talking about hormone levels.
Right. That's why checking them, a lot of women will say, well, my doctor checked my hormones, they said they were normal.
Right.
But you can't dismiss someone's symptoms. It might have been normal on Thursday at 4, but you check again a week later and they could be low. And it just doesn't, you treat the symptoms.
And how do you treat the symptoms?
With hormone therapy. Also, I'm very, very big on lifestyle medicine because you can't just suddenly give someone, well, sometimes if someone's having really bad hot flashes and you replace their estrogen, they're like, oh my gosh, I feel amazing. But it really, besides the hormones, I really focus on lifestyle medicine.
And what do you consider to be lifestyle medicine?
So how we take care of our bodies, how we move our bodies, the right way to exercise, the best way to exercise, which changes with age, how we feed our bodies. You can't get away with a shitty diet anymore. You have to really focus, especially menopausal midlife women, we have to focus on protein and fiber. Really, you can't underestimate that. How we sleep. Sleep is critical. Sleep is so critical, and I can tell you years of my lifestyle not sleeping and working nights to days and swings, being on a normal sleep schedule, oh my gosh. it's
Are
huge.
you on one now?
I am
with your
on a normal
schedule?
sleep schedule now, and I'm like a new person. It's
Yeah,
amazing.
I can't even imagine how
Right.
the medical profession or anybody who may work that third shift,
Right.
how it affects their
It just,
sleep.
you always feel jet lagged.
Yeah.
You always feel jet lagged. And women who are doing a million things, the sandwich generation doing a million things, so many women are not sleeping enough.
Right.
And that affects everything. It's not just feeling tired. It's not just affecting the brain fog. It affects your whole body composition, how you handle everything.
So how do you fix that sleep? Because
There are a lot of ways to fix sleep, and that sleep is one of the biggest problems
Yes.
I have. Actually, I have a follow-up with an amazing woman today, and when I first met her, she said, if you can just get me sleeping, I can handle anything.
So true.
Some of it's hormonal, a lot of it's hormonal. Some of it is just normal aging. Some of it's just this is the age when we have a million things happening at once. You know, you've got kids, revolving doors. Some are leaving the house, some are returning. You've got your parents who you're stressed out about. You could be the peak of your career. There's so many issues going on
Right.
with sleep, and so I approach sleep from multiple directions.
I just love that you said there are so many ways to fix sleep.
I know.
Because sleep is such an issue.
Right.
It's for so
Critical.
many people. I mean, I know my clients, I have so many clients, and you too, who are moving, and it's very rare that anyone
Stressful.
is moving from A to B. There's always different things that are happening, right, or different places things are going, and my clients always say to me, like, I'm not sleeping, I can't, and it's for different reasons. So
Yeah.
they may or may not be in menopause,
Yes.
but it's
and,
just,
and missing one night of sleep, you can get by, but continuous sleep loss, it ages us. I mean, your body needs to recover when it's sleeping. Your brain needs that recovery time.
And I don't know one female that's in my age group, give or take 10 years, that doesn't complain about sleep.
Yes.
right.
I mean, every single
everybody.
one of them.
Yeah.
Yeah.
And that's why I don't, I think some people expect too much from one thing. Say, just give me this and I'll be better. It's not, it's multifactorial. It's not just one thing.
And that's what you have to hear. It's multifactorial.
Yes, you can't, it's like people ask me about supplements. You can't supplement your way out of a shitty diet. You can't, say I'm going to take this and not exercise. You can't, there's just so many aspects of hitting
And
it.
alcohol. I know if I have like a glass or two of wine, I fall asleep really easily, but then I wake up like an hour later.
Oh yeah, alcohol, we cannot handle alcohol the way we did when we were younger.
So
Alcohol
depressing.
is a big, I really talk about alcohol with my patient. I ask about how they're using it because you can't handle it the same, and it will mess up your sleep 100%. There was a conference I went to, actually the last Menopause Society meeting. We were joking because there was a reception that night and they were serving wine, and then someone said, all right, everyone just let's have a group chat at 3 a.m.
Yeah.
Because people wake up, you'll hear the classic 3 a.m. awakening.
Yeah.
Everyone wakes up at 3 a.m. So
Yeah.
I would say with alcohol, I usually tell people, minimum to none. Some people are just total teetotalers at this point. They realize their body just doesn't handle it the same way, and it's not good for them. But people enjoy it, or they want it socially. Less is more. And not every day. Some women are self-medicating with alcohol to help with their anxiety and depression and stress, and thinking it's helping their sleep, and it's not. So just less, and just know that if you do, you probably won't be sleeping well that night.
You pay the price.
You pay the price, which is okay. If you're celebrating, again, everything in moderation. I believe everything in moderation.
I agree.
But just be aware it will affect it.
Right.
I mean, to your point of everybody that has the sleep issues, I feel like everybody that I know, when we're together socially, if somebody's having a glass of wine, like we all, everything that you were saying, like the changes we all experience of that
Yes.
too. I mean, these are just like common
Right.
things
Very
in
common.
our age group
In
right
our
now.
age, right. It could be book club,
And right,
We
and
have a
that
glass
there the
of wine.
conversations
I'm not
come
like,
up.
I'm not getting drunk. I have to drive home, but I might have a glass,
Right.
glass and a half, whatever. And
But that conversation comes up.
Oh, all the time.
Right.
Yes.
Yeah.
Yeah.
I know. It's so hard. And,
And lots of changes.
Yes.
Can I go back to something you said at the very beginning? You spend 90 minutes with your patients?
I spent a long time. So, which is so refreshing because in the emergency
So
department,
old school, Dr. Susie. That's
I'm running
incredible.
around. Like, it really depends. The ER, I'll spend as much time with patients as I can, but as you know, like, I could be talking to you and then all of a sudden, a car crash comes in, I got to run all over the place. But here, it's really important to understand someone's goals. So when I have a thorough questionnaire I send to my patients in advance, and I really want them to fill it out as best as they can. It saves time during our meeting, so I can really focus on educating everyone. And a lot of people have, different goals. Not everyone's coming in with the same goals. One woman's goal might just be, just get me to sleep. If I can sleep, I can handle anything. One woman's goal might be, I've totally lost my sex drive. That's my main concern. One woman's goal might be, my mom broke her hip. I know I now have osteopenia, help my bones. Everyone has different goals. And you have to understand the person, their priorities, and their lifestyle. I don't want to just blanket give everyone the same thing. So if someone had, certain conditions, you can't, certain modalities won't be best for them. Right. And I think if you only have 10 or 15 minutes with someone, you kind of just quick, and people don't understand. So for example, I'll have people coming in that maybe they already were started on something. And I explain, here are the options, this is how it works. It's like, oh, they didn't explain it to me. Because a lot of times people don't have time. And in the talk we were at, someone came up to me like teary-eyed saying, I feel betrayed by my doctor. They didn't warn me, they never told me. And I said, don't be mad at your doctor. Either your doctor may not have been trained, in this, they didn't seek the extra training, or they don't have time. Right. Mm-hmm. I mean, a traditional office, you have 10, 15 minutes.
Right.
You can't address all this. So I really make sure my appointments are long enough that people are comfortable, you're sharing intimate information with me for a lot of it. And I want to make sure they really understand.
And they plan for 90 minutes too.
Yeah, I mean, it's typically, I can get it done. I mean, I could do it as fast as 20 minutes, but I think just knowing who someone is, knowing their priorities, and getting into the lifestyle, what works for your lifestyle.
With hormone replacement, how many different ways are there to get that? Yeah.
So I think we're gonna make this a part two.
That's all gonna be part two. I'm just jumping ahead because I'm so excited about that.
There are lots of options. I think a lot of people just think it's the patch and the pill, and that's not true.
Right. Yeah. Okay, so stay tuned for our second session with Dr. Suzi where we talk about that. I can't wait, as you can tell.
So I'm really curious, what about the spouses? Because women probably come to you and they're like, my husband thinks I'm a crazy person, or my partner, like what happens there? Like you can only, I guess you can make them feel better, but how do you address that?
It's hard, and some women will say, I feel like it's all in my head, but it is in your head because it's the estrogen receptors in your head. It's happening in your brain. You're having all these changes. But if you tell a woman who's really irritable and pissy, like all this is happening, she doesn't understand what's happening. If you say it's your hormones, she's gonna, that's not the good approach. Don't say that.
Pie in your face.
I can say that because they've come to me. They know that. Yeah. But it's important for our significant others and our children to understand things are happening. We give a lot of grace to our kids going through puberty. And if you think of this as puberty in reverse, we're not so great at taking care of our midlife women going.
I think that's a really great analogy.
Yeah, I had a bias with saying the word midlife. It really, at first, and I'm not ageist at all. I love older people. I learned so much from older people. And when I would say midlife, it was pissing me off. Like, I'm not midlife, but yeah, I am. So it's okay. I've gotten over that. But we're good. There are major hormone changes in a woman's life. Perimenopause, pregnancy, and puberty. We're pretty kind and tolerant to our adolescents going through puberty. We're very nice to our pregnant women usually. And we understand postpartum depression, all the massive hormonal shifts that can happen. But we really don't give a lot to the perimenopausal, menopausal women. These are women that are supposed to take care of their families, their parents, their kids, everyone, and they're not taking care of themselves enough. And we have to give them grace, and we have to understand these are major hormonal fluctuations happening again.
Yeah. Have you ever heard it explained like that? That is so perfect.
Yeah. So if you think of reverse puberty, but it's actually worse than that because in puberty, how many books are there about this? How many classes are there about this? We need to educate women about what's happening. So even if someone chooses, no one knows. Our mothers were told to suck it up.
But mothers are so good with their daughters when they're going through puberty or their sons, because we know. But nobody really knows what to do with a person going through menopause.
No.
Right.
My kids know now too because we talk about it all the time, but otherwise why would you?
Right.
If no one talks about it, and this deep dark secret, and you just grin and bear it, but you don't realize the consequences that happen down the line. And it's not, puberty, again, we prepare, we know, but going through this, it's actually works. You have longer consequences from it.
Why do you think that menopause is not a section in med school? Why do you think that's never been really taught as a profession or even as a section, within medical school?
Well,
or PA school?
Yeah, women's health was always not as, a lot of our information comes from men. Women were not involved in medical trials until just a few decades ago. It was always based on men because, God forbid, you affect the woman's reproductive issues. It was all focused on obstetrics, having health. It wasn't focused on everything else. So it's just we're just getting all those studies down. It was kind of ignored. And then, we mentioned this at the talk, the Women's Health Initiative study in 2002 that came out. And that's a big thing that caused fear in people. Why are some people scared of hormones? A lot of people say, I'm just scared. It can cause breast cancer. It can cause a heart attack, can cause a stroke. And that was all based on a 2002 study called the Women's Health Initiative study. And the reason, I'll just briefly say, the reason that study came about was because we knew that women did better than men up until a certain age. After they went through menopause, that's we found their risk for heart attacks jumped up, the risk for osteoporosis jumped up, and women who were taking hormones did not have that. The women who were on hormones had longer health spans, longer lifespans, less fractures, less cardiovascular risk. But that was an observational study, so they had to do a real study. And they did this, and they stopped it early and said, oh, no, it's causing damage. But it was misinterpreted and wrong information because the average age in that study was 63. That's not the age we start women on hormone therapy. We started much earlier. These were women that were not very healthy. They were smokers. They already had cardiovascular risk. They were overweight. So already they were much higher risk for all these issues. And as far as the breast cancer scare, the estrogen-only arm had decreased breast cancer risk. They think it was off from the type of progestogen they used at the time, which we're not using anymore. So with modern therapy, we know that it's actually extremely safe and protective. And it's not just treating the obvious hot flashes, night sweats. It's protecting our long-term health. It decreases the risk for many cancers. It decreases your risk for heart attack and stroke. Decreases your risk for osteoporosis. Decreases your risk for urinary symptoms. Decreases your risk for musculoskeletal symptoms. It's an anti-inflammatory medication. And we say medication, it's not really even it is a medication, but it's something your body always saw and is no longer seeing.
That your body naturally produced.
Your body naturally produced.
Well, I remember when we had a conversation and I was telling you that I have hot flashes and night sweats and all of that, and you said to me, there's no reason that you should be suffering through that, and hot flashes are actually not good for your heart.
They're not good for your
heart.
And
I had no idea.
Why?
Not good for your heart. It sets off... It's fight or flight. It sets off all these things. It can cause a lot of spasm. It increases your risk for heart disease and strokes. It's not healthy.
I had no idea.
Yeah. It's a lot of people think, well, I'll just grin and bear it.
Yeah.
I can say, women suffer through lots, and you can get through it.
Right.
But it's actually, you're not just trying to make yourself feel better. It's not like you have a headache, take Tylenol and feel better. You can not take Tylenol and keep your headache. You can still have hot flashes, but it's actually not healthy for you to have this.
Yeah, I have my little portable fan that I keep in my purse because at any moment the hot flash is going to happen and I got to pull the thing out.
But it's not good
for us. Yeah, I'll be seeing you soon.
I would love to see you. And it's also hard, for women. Some women now, because it's kind of hot now. Well, I guess that's a bad term.
Right. No, it's perfect.
Some women who cannot safely take hormones. Let's say they have an estrogen-sensitive breast cancer actively. There are other options besides hormones to help with the hot flashes because we know hot flashes are not good for us.
Yeah. It's just fascinating, when you talk to different people, certain things will sit with you for a long time. And that comment that you've made, I've shared it with so many people because I had no idea.
Yeah.
But when you explain it the way that you do, it makes perfect sense. Mm-hmm. Yeah.
So definitely talk to us a little bit about protein. You hear about that all the time now, of your protein and building muscle.
Yes.
And why that's so important at this stage.
Critical. Critical. Muscle is your metabolic machine. You have to build muscle as we get older, and this is not just hormonal aging, this is chronological, just regular aging. We lose muscle mass and we lose bone mass. But it accelerates dramatically during the perimenopause menopause transition. We lose a ton of muscle and bone during this transition, and then it kind of slows down a little bit. But this is a critical time. So your peak muscle and bone mass is in your 30s. So that's when our kids, our daughters, we'd say, build your bone now. And it starts dropping, so you have to do everything you can to protect it.
So you're talking about like weightlifting.
Weightlifting, and it doesn't, people say lift heavy. Heavy really means what's heavy to you. It's where it can be resistance training, whatever it is to get your muscle to fatigue. And a lot of women will say, I'm exercising the same, I'm doing the same, my body feels different. We're so used to the old be skinny and just do cardio, and that's not good. You'll get the cardio. I'm not saying don't do cardio. Everything's important. But the variety of exercise is important, and building muscle is crucial. So strength training can be lifting weights at the gym. It can be resistance bands, but you have to build muscle. You have to build muscle. Building muscle will help protect the bones. It helps your metabolism. It helps your body composition, everything.
And then Jasmine was asking about protein. So
Yeah.
you need the protein in order to
You need a
build the
protein
muscle.
bit. So every meal, I always advise people, when you sit down to eat, think, where's my protein? So every meal should start with your protein. And actually, our insulin resistance gets worse during menopause too. So
What does?
Your risk for diabetes goes up.
Oh, okay.
So that's everything else.
On top of everything, your cholesterol goes up, your risk for diabetes goes up, and this protein can help with that too. So eat your protein first, and the goal is about 30 grams 3 times a day. So you want to space it out throughout the day, but the FDA requirements are actually much lower than what they say is actually much lower. So kind of ideally think 30 3 times a day. You want to upload it in the morning as much as you can. So in the morning, like Greek yogurt or eggs or a protein smoothie, supplement with protein powders and stuff when you need to, but whole foods usually best. So start with your protein and then put everything around it.
Yep.
So protein goal is about 30 grams 3 times a day, but it's not as hard as you think. It's a portion of a meat, fish, is the palm of your hand. That's at least 20. Beans are a great source of protein and fiber together. Greek yogurt, cottage cheese. Yeah, I know there's so many memes about cottage cheese. But again, this is when I talk to people, because some people are like, I don't like that, I don't like that. We have to figure out what's going to work for you, because it should be easy and it should just be habits. I try to have people just build easy, healthy habits. Nothing should be hard. Nothing should be complicated, because these are habits you're going to do every single day of your life.
All right, so if a woman listening right now could only focus on 3 things, what would you say those 3 things should be?
Optimizing sleep, optimizing strength training, stop thinking, just optimizing sleep, optimizing strength training, and healthy diet.
Okay. All right. Well, we are going to have a part 2, but we wanted to thank you so much for being here.
Thank you.
If anybody wants to connect with Dr. Suzi, we will have all your contact information in our show notes.
Thank you.
So, and I think you gave us such great information.
Thank
I can't
you.
wait for part 2.
I can't wait for part 2 either. I'm already jumping ahead, right?
Well, because there's so much we
about.
want to hear.
So much to talk
So
about.
thank you so much for coming.
you.
Thank you so much, Dr.
If you know
Suzi.
anybody who would benefit from this podcast, please share it with them. We have a new website now too, called helpnobodytoldme.com. And tune in next week for another episode.
And on my website, I do have resources with some position statements. So if you want to read Menopause Matters MD.com and look under resources, I have a lot of good information there.
Fabulous. Thank you
Thank
so
you.
much for your
Thank
time,
you.
Dr. Suzi. And stay tuned for part 2.